Dr. Thomas practices geriatrics care at the VA Geriatrics and Extended Care Division, and she's currently an advanced research fellow in geriatric medicine at the VA Puget Sound Healthcare System. She received her medical degree from Dartmouth Medical School, completed internal medicine residency, and a geriatric medicine fellowship at UW. Dr. Thomas's research focus and clinical interests are in transitions of care and healthcare utilization for patients with dementia. And she's going to talk with us today about the rational approach to preventive care for persons with dementia. Welcome, Dr. Thomas.
Hi all, thank you so much for dealing with me while I fix my technical issues. I'm lucky being a provider for folks that are elderly that I get a lot of at least empathy in that area for not being the most tech savvy person. I have no financial disclosures to share with you today. I hope that by the end of this lecture, you'll feel more comfortable with the idea of prognosis and how that differs by types of dementia, that you'll be comfortable with the concept of horizon of benefit and be able to think about how that impacts primary, secondary, and tertiary prevention needs for patients with dementia, and that all of this will be seated within a focus on patient-centered approaches and keeping the patient, of course, at the center of the decision-making that happens in all care situations. I wanted to start today with a case of a patient that I've now been seeing for about a year, but this case is from the first visit that I had with him and his wife, and particularly his situation was brought to light in thinking about this lecture series because although he was multimorbid, as you can see, with hypertension, hyperlipidemia, an enlarged prostate, COPD, and a moderate dementia, his wife was still really focused on wanting to be able to think about cancer screening for him, in particular colonoscopies and prostate cancer screening. He, at the time he came to me, did not have any documented advanced directives or goals of care, but was starting to require more assistance, as is often the case with folks at this level of dementia. And so a lot of the concepts in this lecture were things that I had to talk with he and his wife about as we got to know each other and move forward with his care. So I want to start first with several different topics and make sure that we're all on the same page about what those things are. First, I wanted to start with the idea of a prognosis, which is the forecast of the likely course of a disease. Obviously, none of us have a crystal ball, but we try to do our best as providers in guessing what is going to be coming next for our patients. My favorite tool that is for all comers and not dementia specific is the ePrognosis tool out of UCSF. And if you go into this tool, you'll find that you can choose several different types of prognoses to look after. One type is the consideration of what somebody's prognosis is going to be just within the next year. And for that, this tool uses the GWEC index. One of the questions as part of the GWEC index does ask about dementia, but the GWEC score is based off of all sorts of comorbidities that somebody might have. And so I filled in the details of the patient's case that I just shared with you. And for him, this tool indicated that his likelihood of survival at 1 year, that he was likely a risk of mortality of about 8% in the first year. I'll have to be honest that I often find that I'm thinking less about what's going to happen in the year ahead of me with someone with dementia and more likely what's going to happen in the next 5 to 10 years. And so for that, the Lee-Schonberg index that's available on this website feeds out mortality at 4, 5, 10, and 14 years. It collects a lot of different information. You can see in just this screenshot the patient's age and sex and their BMI. There are a handful of questions that do get at changes that one might expect to happen with someone with dementia, loss of functional status, and then particularly whether a memory problem might lead to their difficulty in keeping track of finances or with their self-care. And for our patient filling in this In this index, we get a risk at 5 years of about 40% mortality, in 10 years about 60 to 70, and in 14 years around 80% mortality. So helpful to kind of fill that in and see if that's surprising either to you or to your patient. This is something that I often do in visits or share with patients' caregivers to think about doing at home and review and kind of play with the different features and see what scores they get. For those of you who are more interested in dementia-specific prognosis, there is not a nice fancy tool that is patient-centered that I'm at least aware of. I'd love to hear if others listening to this call have found tools like this. But in Sweden, they have a very large registry of patients with dementia, more than 50,000 people in their registry. And they have looked at the survival for those folks that participate in their registry. They looked at the survival and they split it into folks with dementia who get care in memory care units or have visited memory care clinics. And I think that's a little different than what most of us are dealing with in a primary care space where folks may not have gotten to a memory care group. And so I pulled the just primary care folks with dementia diagnosis. And I want to emphasize for this, that this is talking about prognosis from the time of the diagnosis of dementia, which, as we all know, is likely already in progress before it's recognized by the medical community. In this case, they split the data between sex, with the men at the top here and the women in the bottom, by age, with the older folks at the top of each group, by dementia severity, which here is by an MMSE score, which is a score on a test that goes from 0 to 30, with a higher score having less severity than a lower score. And then on the bottom, they've got a comorbidity index, which is similar to the Gagny index we saw used before, and it just tracks the number of comorbid conditions somebody has. And all this is to say that the purple boxes are worsening probability of surviving for 3 years. The green is better, with the best case scenario being the darkest green color down in the left-hand corners of each box, where the younger people who have got less comorbidities, regardless of their score on the dementia severity, are, in this case, around 90 to 100% likely to be surviving around 3 years, versus if you go up to the top-hand corners of these charts, in the oldest, most comorbid conditions, that we get up to less than 40% of people surviving 3 years. So quite a range of survival that they saw in their cohort. I also was interested to see what we knew about dementia by subtype. Unfortunately, this is an area that's still being researched in the literature, but from what I could tell, on average, we estimate a 5 to 8 year survival from the time of diagnosis to death for folks that are diagnosed with dementia after the age of 65, which we call late onset dementia. Obviously, there are a lot of confounders to think about, whether or not folks have got as much social support, different races, different comorbidities, different ages at the time of diagnosis. And for all comers, it appears that there is some evidence that those with vascular dementia do survive less long than folks with Alzheimer's dementia, likely because they've got more comorbidities to deal with. Out of the same Swedish registry group, there was a study that looked at this survival curve with, on the vertical axis, survival from the 1 being everyone has survived, down to the bottom at 0.4 being only 40% survival, and tracking out for 5 years, or in this case, they on their x-axis have days. And you'll see in general that the Alzheimer's group is kind of in the middle of this pack, and the folks that are underneath them are vascular dementia, Lewy body dementia, and frontotemporal dementia. So acknowledging that not all types of dementia have got the same kind of survival, But you'll see with most of them, there's less than half that are surviving at the 5-year cutoff that this study looked at. My next concept is the idea of a horizon to benefit. And this is a concept of thinking about how much time you need. The one slide back, which I was just going to point out the concept of the 4 M's and keeping that in mind. You already have introduced that idea, and in particular, I want to point out that what matters to patients is really key in all the decision making that we do where we are talking through these decisions with patients. Go to the next slide. My next concept is the idea of prevention, which we split into 3 different groups. The first is primary prevention, where your goal is to prevent getting a disease like a vaccination. Secondary prevention, where our goal is to detect a disease early so that we avoid it getting worse. This is where most cancer screening goes. And then tertiary prevention is someone's already got the disease and you're working hard to improve their quality of life or reduce the symptoms that they have. So like cardiac rehab would be an example of that. Next slide. So some caveats to all the recommendations that are to come, which is to say that I attempted where they existed to pull recommendation guidelines for older adults. So things like the US Preventive Task Force or the American Cancer Society. I will say that these recommendations from these societies are built upon research that often excludes individuals with dementia. And so there are instances in which I am making recommendations based off of expert opinion and also off of personal clinic experience, having trained here in Seattle with some excellent geriatricians and working with other excellent geriatricians at the VA. And so what I am sharing is consistent with the care that I have seen be given in our institutions. Next slide. So we're just going to start with primary prevention. Next slide. So to start, overall, I would say vaccinations for folks with dementia are recommended across the board. That includes tetanus shot every 10 years, both types of pneumonia shots once somebody's over age 65, acknowledging that the 13-valent pneumonia vaccine is particularly important for folks who are in nursing homes. The influenza vaccine each year, the shingles vaccine once somebody is over 50. Now that it is becoming available in our community, I think yesterday in Washington State moving to 1B, but prior with residents of nursing homes being 1A, highly encourage all folks with dementia to get those vaccines. Next slide. Exercise is an area that is under a lot of research because there's a lot of hope that we might be able to prevent dementia. The focus of this lecture is not on all of the things that one might do to prevent dementia, but I will acknowledge that it's unclear at this point if it lowers your risk of dementia or progression to exercise, but it is clear that exercise helps with mood and can help with other comorbidities that folks with dementia often have, including hypertension and heart disease. I try to remember and encourage caregivers of folks with dementia to encourage exercise where they can, but acknowledge that the apathy that can come with advanced dementia can lead to difficulty in motivating people with dementia to exercise, and that this is an area where we encourage gently, but if it creates fights and agitation, it's not something that's worth pursuing. I do encourage partners who are interested in helping their loved one do physical therapy, that often can work, and it is excellent when we can to maintain functionality as long as possible. That places less caregiver burden when a patient is able to maintain their own function. Next slide. Diet is in the same position as exercise, a very hotly researched area. Unfortunately, there is no known cure or diet that either decreases risk of dementia or limits the progression other than keeping a healthy diet to decrease the risk of other chronic diseases that might increase our risk of getting dementia, particularly a vascular subtype. I will acknowledge that folks with dementia often have impacts on their appetite, swallow, and cravings, and particularly the frontotemporal dementia folks, their caregivers can have a lot of difficulty in maintaining a healthy diet. That overall, at the end of life, just a reminder that feeding tubes are not recommended in the dementia population to minimize aspiration or extend life. Next slide. So moving into secondary prevention. Next slide. So first, thinking about breast cancer, the 50 to 74-year-old group currently has a recommendation from the U.S. Preventive Task Force to consider mammograms every other year, with no evidence of clear benefit or harm above the age of 75. The American Cancer Society is a little bit more clear, I think, in indicating that it's reasonable to consider continuing breast cancer screening if somebody's health is good and they have a life expectancy of 10 years or longer, with the idea that you're unlikely to get benefit from detecting a breast cancer if someone doesn't have 10 years left of life. And just a reminder that currently no guidelines recommend breast self-exam or clinical screening exams to search for breast cancer. Next slide. In prostate cancer, the U.S. Preventive Task Force is very clear that if an individual is over than 70, they recommend to not screen. The American Cancer Society is a little bit more open and has a very similar comment as they did with breast cancer, which is the idea that if somebody should have at least 10 years left of life expectancy to engage in a conversation about the pros and cons of screening for prostate cancer. Next slide. In colon cancer, this guidance from the U.S. Preventive Task Force is actually under a draft statement with ability for folks to give feedback. That draft statement is actually shifting the age of starting to think about screening downward and has made no changes for the eldest folks in the cohort. So current recommendations are for a shared decision-making conversation when folks are between 76 and 85, and a recommendation to not screen if someone is older than 85, with a clear indication that in the oldest cohort, the likelihood of benefit is small, and that you really need to think about the person's overall health and prior screening results in making that decision. The American Cancer Society, again, is emphasizing that if you don't have 10 years of life expectancy, it's not recommended to do screening for colon cancer, and that once you're over 85, that no one should be getting colorectal cancer screening. Next slide. For lung cancer, again, this is an area that is under draft, and the draft is again considering including a younger cohort in screening. I will emphasize that the data that supports doing lung cancer screening is based on a study that enrolled adults only up to the age of 74, and only 10% of that sample was older than 70. So this is particularly very limited data for the cohort of patients that are most likely to have dementia. Also excluded from that study were those that had conditions that gave them a risk of death in the next 8 years, which, as we already reviewed for dementia, would include most patients with dementia. But current recommendations are between ages of 55 and 74 for the American Cancer Society, or 50 and 80 for the U.S. Preventive Task Force, that it's reasonable to consider lung cancer screening if you've had a history of smoking or have quit recently. Next slide. Cervical cancer screening per the U.S. Preventive Task Force can stop once somebody reaches 65 if you've had 3 negative tests in a row or have had a hysterectomy and no abnormal PAPs. And once you stop that screening, even if someone changes sexual partners, they should not have a screening for cancer, which is different than if they obviously complain of symptoms, then those should be looked at. Next slide. And so in summary, for all the different kinds of cancer that I've just reviewed, my encouragement would be to discuss with patients stopping screening for cancers. That once somebody has a diagnosis of dementia, given that average prognosis of 4 to 8 years across all kinds, and the horizon to benefit estimated at 10 years for each of these cancer types, screening should be discouraged. I want to particularly emphasize that for patients with dementia, colon cancer screening that includes direct visualization through a colonoscopy or a sigmoidoscopy is particularly hazardous to folks with dementia because of the heightened risk of delirium associated with anesthetics. And so this is an area where I push back more stringently in the conversation and weighing the risks and benefits than with the other kinds of cancer screenings where the harms are less immediately present. Next slide. A few non-cancer secondary screenings to consider. One is osteoporosis screening, and this is one that I think is reasonable to do for folks with dementia, that the U.S. Preventive Task Force recommends screening once somebody hits 65 if they're a female, and believes that there's insufficient evidence for men at this time. The Endocrine Society did indicate that if men are over 70 or who are 50 to 69 with risk factors like prior smoking or fractures or low body weight, that it's reasonable to screen them. The current horizon to benefit in the literature for engaging in osteoporosis treatment is in the 2 to 5 year range. And so most folks upon diagnosis with dementia would potentially live long enough to receive the benefit of that treatment. I will indicate that I do a lot of treatment with IV bisphosphonates instead of oral bisphosphonates in this group, given the difficulty with memory and remembering to take what is often a once weekly therapy if you keep an oral, as well as the difficulty in remaining upright, which is needed to avoid pill esophagitis with oral bisphosphonates, which are the most common first line agent to treat osteoporosis in a non-dementia population. So IV bisphosphonates are reasonable to consider with folks with dementia. Next slide. Abdominal aortic aneurysms, I would encourage to not consider doing. This is a one-time screening recommendation currently for men only who are ages 65 to 75 with a history of smoking. And given that there is limited evidence of the risk-benefit ratio with the current repair that's needed, which is mostly an open repair, although some folks have got non-open repairs, the risk-benefit ratio is likely leaning in the side of not looking for these kinds of aneurysms in folks that have been diagnosed with dementia. Next slide. Hearing loss screening is something that does not have enough evidence to be advised by the U.S. Preventive Task Force. I will encourage that if you notice patients having hearing loss, it is a strong risk factor for getting dementia, and it can impact the ability to be able to tell if somebody has got an attentional deficit or a memory deficit, and certainly can impact performance on memory testing. In our clinic, we often provide pocket talkers to patients to help them be able to participate and hear better. And I do find that the cognitive reserve needed to be able to use a pocket talker is far less than hearing aids, that it can be really hard for patients with dementia to learn to use a hearing aid. And I have had very little success, even with early dementia, getting somebody to start using a hearing aid that has never had one before. But I will say that I have had great success across all stages of dementia with pocket talkers and helping to make our clinic conversations be less one-sided. Next. Vision screening, again, is another area where there's not good evidence in the literature to indicate whether or not it's beneficial or harmful to screen for vision impairment or glaucoma in older adults. But I will say that vision impairment, just like hearing impairment, can increase one's risk to be diagnosed with dementia, and obviously can increase the risk for falls, which are a common source of morbidity and mortality for all elderly patients, including those with dementia. And so I think paying attention to whether patients with dementia have got appropriate visual correction when needed is a good thing to do if they're caregiver and they are up for trying to have that corrected. Next slide. Hypertension is an area under a little bit of debate currently, but I will say that current guidelines from the American Heart Association, which are getting older, they're back in 2014, are that blood pressure goals for all patients over 60 should be to be less than 150 over 90, unless you have a history of diabetes, and then it decreases to 140 over 90. There was a lot of news in the literature in 2016 around a Sprint senior trial that looked at patients that were over 75 years old in a trial that looked at whether or not people did better or worse with cardiovascular outcomes when they had very tight control of their blood pressure, systolic blood pressure less than 120, compared to folks that had less tight control of their blood pressure, allowing their blood pressure to be just less than 140. In that study, they did show that there were similar rates of falls and orthostatic hypotension, two things you worry about when you tightly control blood pressure between the two groups. But I will point out that much like many of the studies we're looking at, folks with dementia were excluded from this group, as were folks with a lot of other comorbidities. I do think it's really important to pay attention when you're balancing your blood pressure goals to think about the risks of overtreatment in this cohort. But I will say that one of the most common things I see when someone with dementia is coming to me for the first time is instances where with their dementia or with their other comorbidities, they've lost weight over time and their blood pressures with that loss of weight have gone down over time, and their blood pressure medicine dosing has not kept up with that. And so I often find myself down titrating blood pressure dosing in this population. And I think it's important to make sure that we're not causing harm by over medicating these patients. In particular, there's a high risk in diuretics in this group of falls from trying to go to the bathroom, all the nocturia, from hyponatremia and with kidney injuries. And so avoiding diuretics as a subtype of blood pressure medicines is important if you're able. And then also considering the role of white coat hypertension and not viewing a one-time high blood pressure in your clinic as an indication that somebody needs treatment, and rather encouraging you to have the patient and their caregiver collect blood pressures at home to get a grouping of blood pressures to be able to make decisions on. That I often will see somebody in clinic who has come in here at the VA, the long trek from the parking garage over to clinic, that they get their blood pressure taken right when they get in clinic by my nurse, and their blood pressure is elevated. But if I check at home, it's within a normal range or even on the lower side. Next slide. Diabetes management is another area where often folks with dementia have had a long diagnosis of diabetes and are used to a very tightly controlled blood sugar. And it can feel funny to them when I encourage them to loosen their A1C goals to be more in the 7.5% to 8% range, to be in conjunction with the American Geriatric Society, or the American Diabetes Association also has an even higher recommendation of 8 to 8.5 for those who are older with complex medical issues. that in my reading about this, keeping a A1C below 9% is where you're likely to not have side effects from hyperglycemia in the immediate case, and are unlikely to also get the risks of hypoglycemia that are unfortunately really elevated in a population that does not necessarily with dementia eat consistently, does not necessarily remember to take their medicines consistently. And so erring on the side of having a slightly higher A1C, a slightly higher blood glucose, is likely less risk to your patients. I was there in this Accord and Advance trial. They did show increased risk even of cardiovascular events for patients who have hypoglycemic episodes, likely secondary to the catecholamine surges that happen when you are hypoglycemic. So you can feel like you're saving your patients from heart attacks and strokes, and unfortunately maybe putting them at higher risk of those if they are hypoglycemic on too tightly controlled blood glucose. Next slide. In hyperlipidemia, there's also really limited evidence about what our treatment goals should be. There was an article published this last year that did look at patients who were 50 to 75 with no history of coronary artery disease. And in that study, they showed that it took about 2.5 years of taking a statin, our most common cholesterol medicine, to prevent one major cardiac event. So this is a space that is a little bit more under question. I would say that I do not currently start primary prevention with a statin for folks over 75. And if somebody has dementia and I'm considering their time to benefit, that is likely, at least here, at least 2.5 years to benefit for a younger population, 50 to 75, potentially longer timeline for older, unclear, and potentially with side effects including the musculoskeletal complaints that folks can have on statins, that it takes a shared decision-making conversation to weigh those benefits and risks. There is a trial that's coming, the STAR-E trial, that we're anticipating to look at the benefits of statins in people 70 or older. So hopefully next time I get to give this talk, we'll have more information coming. Next slide. So all this to say that appointments with me as a geriatrician can come at a surprise when folks are used to going to the doctor and having medications added upon. And I have conversations where I start talking about removing medicines or not doing things that folks are used to doing and that they feel are the things the medical system has taught them to do, that good preventive care where we look at doing our cancer screening. And so these conversations can be really, really difficult, as you might imagine. Luckily, there are studies that look at what patients prefer to be said to them when we have these kinds of conversations and try to have shared decision-making about limiting secondary prevention. That patients have emphasized that they prefer if doctors encourage them to think about not just that they're not doing things, but instead that we think about what we are prioritizing and what health issues we are going to focus on instead of the cancer screening, so that it's not a sense of having less care, but just care that's focused in a different way. Patients shared that they preferred language that indicated that tests will not help them live longer over language like you may not live long enough to benefit from this test. Next slide. And I pulled this from a study by the same author looking particularly at language preferences in discussing stopping colon cancer screening. And this author did a really beautiful job. This article I highly recommend. She's in over at Hopkins, and so she looked at a local population that had very low health literacy and then looked at a general national population with higher health literacy. And for all these populations, the phrases at the top of this chart were more preferred than the phrases or the decision to not talk about it at all at the bottom of the chart. So again, as I said, pointing out other health priorities that are important to focus on, pointing out the guidelines was very popular, pointing out that you're less likely to benefit, normalizing it, that there is an age cutoff at which we normally stop doing these kinds of studies, and then focusing on the risks of harm, which in particular with colonoscopies, as we discussed, can be not insubstantial. Next slide. So tertiary prevention, which I view as a space that if I'm not going to do the secondary prevention things we've talked about with somebody with dementia, these tertiary prevention items are the things that I do want to focus on and spend time in visits encouraging and facilitating. Next slide. So the first is to help patients and their caregivers think through what their goals of care are. That this is really important to do as dementia is a progressive disease and as the patient is likely to be able to participate in this conversation less and less as time goes by. Having this conversation early on can be really helpful. I do want to point out that the University of Washington has some internal medicine doctors who've created a dementia-specific advance directive. I've given you the link here that looks at some common occurrences that can happen as dementia progresses and gets the caregiver and the patient with dementia to consider those circumstances and document their goals of care. And I think that going through a form like this is really helpful. I also will say that having the occurrence of COVID and having patients be really aware that there is a disease that's present that is of high risk for the elderly population, and knowing that goals of care are going to be considered if somebody gets hospitalized. It's been a really helpful time for me to encourage all of my patients to take this seriously and to document their goals of care now, so that the care that they might need in the future is closely consistent with what they want. Next slide. It's also really important, and this is a space where we do, I think, a better job in healthcare of encouraging healthcare attorneys, durable power of attorneys. We do less of a good job thinking about financial power of attorneys. I want to encourage both to be thought about in early dementia so that when folks get to late dementia, you're not stuck in a bad situation of no power of attorney being established for financial matters and lengthy court cases and things having to happen to be able to get a financial power of attorney established. There is a link here for finding an elder law attorney, and they can help with the paperwork that's needed to establish a financial power of attorney for a patient with dementia. And I will say that most of our advanced directive forms available in our health systems include a healthcare power of attorney automatically. Next slide. Another area that is a difficult conversation to have, but important to start having in early dementia is the idea that patients with dementia will reach a point in time when they will need to limit and stop their driving, and that it's important to work with the patient with dementia and their family to make plans and think about when that will be and think about what they will do for alternatives for transportation when that time comes. Talking through specific risks of driving too long with dementia, including accidents, getting lost, potentially harming others, having legal liability from that harm. Both occupational therapy and our neuropsychiatry colleagues can help weigh in on patient driving safety. And the Washington Department of Licensing also does driving safety exams that can be really helpful for patients and their families to assess, is it still safe for my loved one to drive? Next slide. I wanted to encourage as well, I really like this resource at the Hartford Center, available on their website about safe driving at the crossroads. And it provides specific suggestions for families to monitor, limit, and stop driving, and has experiences of other family caregivers and persons with dementia. It's a really nice, they will send you a booklet, and they're also available online. Next slide. The Alzheimer's Association also has got a really nice section on this issue with, as you can see, videos that you can watch with individuals with dementia and their family discussing this problem. And I will say that this is an area that families well, not like, but often want to avoid because it is contentious and it's hard. And I think that trying to deal with this conversation many times over time will help ensure that when it's time to stop driving, that it actually happens. Next slide. Gun safety is another area that I think is important to talk about once somebody's got a diagnosis of dementia, to talk through the high risk of accidental harm to loved ones with the paranoia that can sometimes occur in folks with dementia, where they're worried about somebody breaking into their home. And so I encourage folks, there's language here that I included around needing to retire from driving and retiring from firearms. And I use that language, retiring from or graduating from, pretty commonly. That we are all used to these ideas of graduation from things and retirement as, I guess, ceremonies that we all go through in life where we have changes ahead, and acknowledging that for everyone's safety, coming up with a plan to maybe give guns away to family members and make sure that the next generation is able to enjoy hunting, to acknowledge that there are likely higher risks to having a gun in the home with someone with dementia than there are benefits to preventing burglary or something else. And unfortunately, a very quick Google search for any of you would show more articles than there should be around inadvertent harm happening to persons with dementia and their caregivers from accidental gun use in the home. Next slide. Another area that I like to discuss with folks with dementia and their caregivers is thinking about utilizing home safety evaluations to be able to preemptively think through how one can make one's home more dementia friendly and more friendly for somebody who's got a lot of frailty. That I'm lucky to live in a system clinically like the VA, where my occupational therapists are able to do video visits here in the COVID era and look around somebody's home and look for evidence of need for grab bars and toilet risers and tools like that, as well as look for things like throw rugs that might be fall risk, cords hanging in the wrong space. I've given you a link for a home safety assessment that the Alzheimer's Association has made available for folks to be able to do this on their own if they don't have access to occupational therapy. And then if you've seen somebody and are able to do a home health referral to occupational therapy, this is something that home health agencies are excellent at doing. And I've given you an example. I've had a home health agency make recommendations for several of my patients living in adult family homes of disguising doorways for folks with dementia that like to wander. And it's remarkable how just a simple disguise of the doorway, like you can see here, turning it into a bookshelf, can decrease that desire to run away where you don't have a sense of where the door is that you can leave. And I want to really encourage folks, as one of the areas that I see commonly causing problems in moderate dementia, thinking about cooking alternatives and safe cooking strategies. And addressing the risk of hot water and risk of burns with cooking, and coming up with plans with families to think about how to get their loved one food safely, whether that be using the microwave exclusively, potentially thinking about removing knobs from stoves, or stopping electricity or gas supply to stoves in advance of somebody creating accidental harm to themselves. Next slide. Another area that I try to address with all of my patients once they have a dementia diagnosis is discussing the risks of hospitalization with the person with dementia and their family member. That unfortunately, folks with dementia have double the risk of hospitalization as their age-matched peers. And when they get in the hospital, they have an increased risk of delirium. They have an increased risk of not moving enough and losing their functional status that was allowing them to be able to remain at home with a caregiver. And then there are commonly, unfortunately, errors that can happen with over-medicating dementia-associated behaviors, not recognizing what's happening in the hospital, not being aware when you see somebody has dementia, thinking that their baseline maybe is really awful, and not recognizing that they're actually really ill and that normally they can talk, and here in the hospital they're ill and can't, or viewing symptoms that are happening and new onsets of problems as being associated with dementia and not being a new problem. I will say that hospitalization, unfortunately, in the era of COVID, where visitation has been minimized, can be even more risky for somebody with dementia, where their caregiver is not able to be as present and not able to advocate and play that same role in helping them through a hospitalization. So thinking through what to do when somebody's ill, making plans for alternative assessments, whether you're in a system that's got a hospital at home program, or whether or not the doctor has got a call line that can be used for triaging problems before considering hospitalization. Discussing seeking out care early when problems arise, rather than waiting for them to get worse. All of those things get discussed in visits with my patients with dementia. Next slide. And then discussing and normalizing caregiver burden, acknowledging that the care for somebody with dementia is and can be a challenging thing to do, that folks are having to do this often longer than other diagnoses like cancer, that can have a shorter horizon of benefit, a shorter prognosis, than a dementia patient could have. That most of these caregivers are women. Most of them, a good portion of them, are older. A lot of them have got depression as a result of their burden with the caregiving and the limitations of their own ability to self-care when they're caring for someone else. There are a lot of resources available, even in this time of COVID, for caregivers of patients with dementia. And those resources are at a national level with the Alzheimer's Association, and also at a local level with our Area Agency on Aging, in non-COVID times, adult day health programs, but still some skilled nursing facilities locally doing respites for folks, and caregiver support groups that have moved online. I know the Memory Brain Wellness Clinic at the UW has got caregiver support groups that are happening online as well. So worth discussing and considering referrals to programs to help caregivers talk through options to support them. Next slide. And then I just wanted to throw one slide in here about COVID-19. I see that you're going to have a talk about this later in the series, but to acknowledge that unfortunately, given that folks with dementia are older, they are at heightened risk of COVID infection, that it has been very common for my patients with dementia who have gotten COVID-19 to present with an altered mental status, appearing to be delirious. I've had folks be confused and think that their loved one is having a stroke. And so to be aware that that's a common presentation, to be aware that although visitation policies have been reduced, that many of our hospital systems do have carve-outs for caregivers of patients with dementia, and that caregivers should ask the teams caring for their loved one in the hospital if there is a carve-out to allow them to be able to best advocate for their patient if they feel comfortable being at the hospital. And then acknowledging that in this time of COVID, that some of the caregiver burden resources that exist have been stopped, like the adult day health programs. And so there need to be unique methods to reduce burden. And I know that all of the Alzheimer's Association, the Doris Duke Foundation, have got all sorts of really interesting and creative ideas. And I've given you one link to the Alzheimer's Association guidance. And I think there's a really nice video from Teepa Snow on talking to patients with dementia about what COVID is and helping them try to understand why their lives have changed so much and why they're having less visitors, why they're not able to do the kinds of things they maybe used to enjoy, like going to restaurants or going for drives, things like that. And then this picture is just of a grand pad, which is a technological solution for limited technology generation to simplify the ability to communicate via technology. And it's exciting to see those kinds of platforms develop more in this era. Next slide. So in review, we covered a lot of material today, and I'm looking forward to your questions. But if you take away nothing else from this talk, it's that dementia is unfortunately a terminal illness, and that the prognosis for folks with dementia is on average from the time of diagnosis 4 to 8 years. And so when you're thinking about the treatments that you're offering for patients with dementia, if they have a horizon to benefit that's longer than that interval, like most cancer screenings, then you should not be offering that to those patients, or you should be offering it with the caveat that you're concerned that potential harms from those screenings are worse than are more than the benefits the patient is to receive. That there are some treatments that still make sense, like osteoporosis for many people, if screening, looking for that. And that for everyone with dementia, taking time with these tertiary screenings to improve the quality of life that someone has and try to lengthen their time of being able to be home independently if that's consistent with their goals, I think are worth the time that those efforts take. And then ensuring that any care that you give to patients is patient-centered and is focusing on the goals of the person with their dementia and their family. And that remains front and center of any decision that you make in the care visit. Perfect. Next slide, which I think is just questions. Thank you so much for your time, everyone.
Okay, I'm going to stop sharing the screen so I can maneuver various questions and things. Please feel free to pose your questions in the chat. We have a couple that are already there, and so I will go to those first. I can find it. I'm going backwards here. So how do you account for symptom onset with diagnosis? Often symptoms seem to present prior to diagnosis.
Yeah, it's very hard to account for that. And I will say that the data that I present is about looking at things from the time of diagnosis, because that's what's able to be studied. That obviously, depending on how connected somebody is to a health system, whether or not they have a caregiver that's present that can share concerns earlier about memory losses or functional losses earlier, that there are a lot of factors that influence when somebody is diagnosed. And certainly, I guess you could add on acknowledging that there are some patients who are going to be diagnosed very early on who are going to have a longer pathway than the 4 to 8 years that I'm sharing. And so when you are contemplating what you're offering or not, you have to take that into consideration. Acknowledging that what we have is what we have, and that's from diagnosis.
Does simply age make a difference with the slight increased risk of diabetes with statins?
So I have not looked over the literature on the risk of diabetes from statins. I know that it is slight, as the question asker is asking, and I am not sure if age affects that or not. I would have to read about that. But I would say that statins are something that often gets started in patients as a goal to do primary prevention, and that when somebody gets over the age of 75 and they don't have diabetes, then I'm having a conversation with all patients, dementia or not, about whether they want to stay on a statin, because the evidence for primary prevention after 75 is not present. And then for patients with dementia who do have diabetes, I'm having a risk-benefit discussion, acknowledging, and the link to I believe I had a paper on the slide that had the the diabetes slide, but in that paper, most of the benefits from statins that we're seeing are 10 years out, that you're thinking about preventing heart attacks and preventing strokes, and the same thing with diabetes, that you're trying to prevent these macrovascular accidents from happening. So it's thinking about what is the benefit you're getting from a tighter blood sugar control or a tighter cholesterol control, and it is likely minimal in folks that have already gotten dementia.
Thanks. Any thoughts about if a dementia patient has goals of care that drastically change as the disease becomes more progressive? For example, you want to respect the original goals of care, but you also want to respect the patient and family at the present state as well?
Yeah, I really like one of my favorite parts of the VA's advanced directive form, which likely most of the audience hasn't seen, is that there's a question on it that asks the person completing it how closely they want the things that they're saying to be followed in the future. And there's a spot for them to be able to say, I want it, regardless of what changes, I want things to be done just like I say on this form, or I want to give my caregiver the ability to kind of gauge the circumstances at the time, knowing me and knowing my preferences, and make a decision that makes sense at that time, even if it contradicts what I said earlier. And I think that's going to differ depending on the individual and their preferences. And I like that question on the form, and I attempt to have that kind of conversation with folks about how tightly they want things adhered to, what are their biggest worries. It can be helpful to talk through family members that have had end of life care or serious medical illnesses, and what happened there and what they liked or didn't like about that care, to try to be able to best understand what they want in the future. But all of us, it's hard, I think, to anticipate what we're willing to go through and what we consider to maintain as a quality of life. So these conversations are hard, and it is, I think, hard for folks to anticipate what they're going to want in the future, although some people can.
Great question. I'm glad it is on the form. So is a blanket informed consent permitted for preventive procedures, or does each preventive procedure need POA review? How do you conduct informed consent for COVID vaccine in a dementia care center, for example?
Ooh, that's harder in a dementia care center where you don't have the caregiver there present with you. That I would view in a dementia care center, I would be looking at the POST form that should be completed by everybody, and thinking about whether or not that person's goals are comfort oriented, which may be less about extending life, although one could say that COVID infection is likely not very comfortable to have, versus somebody that's in a selective or a full treatment space where their goals are treating medical conditions as they come up. And so I would be very clear that vaccination would be the right thing to do. I think vaccination is also hard because you're considering in dementia care spaces the risk of transmission between patients, and that the more patients you have with COVID infections, the more risk there is to others. I guess I'm lucky in that I am not currently having to make those kinds of decisions, that all of my care that I'm giving is in a clinical setting where I am working directly with a patient and a caregiver, or if there isn't a caregiver there, then I've got a guardian ad litem or a guardian that I'm calling, and I am seeking a decision for each of the things that I do in a clinical setting, which may not be feasible or possible in a memory care unit.
Is there anything along the lines of outpatient palliative care for dementia patients with multiple or advanced medical issues?
I mean, palliative care is something that I send patients with dementia to when there are challenging decisions that need to be made about their care, because I do consider dementia a serious medical illness, and at least here at the VA, that qualifies them for palliative care considerations. I will say that the hospice criteria based just on dementia do require very severe dementia to qualify for hospice. And so that can, I think, make people maybe wait very late into dementia before thinking about talking with palliative care. But I view my palliative care colleagues as a helpful resource when very difficult decisions come up, where I need their excellent communication strategies. And I'll say I've been lucky in my training. The University of Washington's geriatric program ensures that we have 3 months of our year of clinical training in palliative care because they understand how often these kinds of decisions come up in geriatric patients.
Interesting. I did not know that. Carolyn asks, are there any new tests or assessments that look promising for dementia patients? And Carolyn, feel free to chat in if you're thinking of tests or assessments in a specific area. But basically, Dr. Thomas, it's new or promising tests or assessments for preventive considerations.
I'm wondering if she's meaning to assess whether somebody has dementia. So if you're thinking about the actual tool that, like we were talking about, the MMSE, she's saying yes.
Yeah.
I think that's an area that is going to be, I'm not aware of brand new tools, that the MMSE is commonly seen in research studies and is less commonly used in clinic. That in a clinical setting, the MOCA has been very, very commonly used. There is some concern with the change in requirement for folks to get training to administer the MOCA, which comes with a payment to get that training, that may push folks to use other tools. I will say that it's really hard. I think it's a lot of research to be able to show that your tool does what the MMSE does, which is kind of your baseline gold standard assessment. And so I think it's a space that if somebody wanted to do that kind of research and build a new tool that was open source so that everyone could use it, then there's potentially a hole for that. I will say that it's an area of hot debate, and I see folks most commonly using a tool called the SLUMS, which is out of St. Louis. It's a VA tool as an alternative to the MOCA, but no, it does, and the SLUMS is not new, but hopefully we'll hear more.
Do you have any recommendations for caregivers who have a loved one who's exhibiting behaviors like anger, frustration, or even violent tendencies?
That's really hard. I think that Dr. Thielke gave a talk, at least if not this year, then in the past has given a talk about behaviors associated with dementia. That I count myself lucky to be in a space where I have geriatric psychiatry colleagues to assist me with that. My general advice for caregivers is to, number one, through anticipatory guidance, help them understand that that's a potential risk. That we do a lot of the 36-hour day book handing out here at the VA to help folks kind of anticipate what might be coming down the line, to encourage caregivers to know that if they are worried about harm to themselves or others that are there, that they should be calling 911, that they should not be being heroes at home and sacrificing their own health and welfare for their loved one, that the medics and folks in emergency rooms are trained to know that people with dementia can have behaviors associated with that dementia, and then to know that there are medications that can help. And I'm not going to go into terrible depth with that, but I will say that medications that I see commonly used as first line are things like memantine, which can be used also for to slow down dementia progression, but some feel can improve behaviors. And prazosin is a very popular medicine used here at the VA, first for PTSD, but also to limit that adrenergic surge that can come with agitation and dementia. And then obviously lots of different antipsychotic choices when the risk-benefit ratio of using those makes sense, given that those have got black box warnings.
Thanks. Do you find that most patients end up in a dementia care unit versus staying at home with a caregiver in your percentages, or what might be percentage in your experience, and what might be percentages of those who end up in a dementia care home versus staying at home?
That's hard. I would say that because as a geriatrician, I would say that I see some dementia cases that are more challenging than maybe dementia cases that are staying with the general primary care team. So I would say that I expect that I am seeing a higher percentage in my own panel that are being cared for in long-term care settings, adult family homes or memory care facilities. That I would say I'm about half and half at this point, and I think that that's high. I would say that most of my patients that are in early stages of dementia really emphasize that one of their primary goals is to be at home as long as possible. And so the work, my clinical work and my research work is all focused on trying to help them reach that goal, which is a lot for me about some of that anticipatory guidance that we talked about in anticipating in advance. If I can prevent a fall by getting their home safe for them, getting them physical therapy where they can participate, if I can keep them out of the hospital, then I'm going to do the best job at keeping them home as long as possible.
Could you repeat the current recommendations regarding a blood pressure of 150/90?
That's the current recommendation for blood pressure for folks that are over the age, I believe, of 60. I would have to look at my slide, 60 or 65, except for folks that have got diabetes. And I would put in that diabetes a similar kind of caveat that if somebody's had a history of a stroke or a heart attack, I also think about a little tighter blood pressure control at 140/90 instead of 150/90. But I'm not sure what else the question asker was hoping for.
Okay. Carolyn is wondering if you could speak to different cultural perspectives on dementia.
Oh, that's a really interesting question. That one of my current research is looking at the patients who are participating in the VA's home-based primary care program, which is a program that does primary care in the home, so folks don't have to come to the medical center, and looking at caregiver burden in that population. And I was really fascinated to realize, and kind of looking at the demographics of people participating, that the African-American patients participating in that group were much less burdened than the white caregivers reporting those scores. And it didn't seem to be associated with having patients that had dementia for a longer period of time, or who were on more medicines, or who potentially were requiring antipsychotics, things like that, that it seems to me to be a cultural difference in how dementia is seen. I would say that there are reports, and I don't have this from personal experience because the VA population does not include, at least in the elderly population, a heavy Asian population here. But there are reports in the literature around Asian cultures also viewing caregiving very differently, and viewing aging very differently than our American culture views that. So there are definitely differences by culture, and I am heartened that that is one of the NIA, when they go through their funding initiatives, one of the things they've emphasized that they want to see in the future is more emphasis on considering those cultural differences in how we target caregiver support.
So Kathy says it would be great for all primary care providers to get this presentation, since most don't have this knowledge to apply it in their practices. And I would say, feel free to let them know that it's posted on our website, but I was wondering if you had any thoughts about that also, Amy, about primary care providers having this background in the rational preventive care.
Yeah, I mean, I would say other than I agree, obviously I'm biased, that when I chose to do a geriatrics fellowship, there was a piece of me, through having hung out with general internists and family medicine providers, that I wasn't going to learn anything from that year fellowship, that it was just more of the same, because already as an internist, I was caring for older adults. And I will say that I feel thankful for the education that I got to point out some of these differences, and that I at least try within my institution to be available to highlight these things and share these recommendations when I do get a chance to consult on a patient that I'm seeing. And that's all each of us can do, right? Is point out the things we notice about a system and the evidence that we know about, and try to improve the care that the patients that we're seeing are getting.
Any recommendations for dental care?
Ooh, I think that dental care can be hard. Well, dental care is challenging right now with COVID because of it's, you can't get it without taking your mask off. And dental care can be really challenging for somebody with dementia that does not want that care. That I think that, like, I have not researched this, so this is my general gestalt without having looked at any research, is that if there's not an infection, or there's not, an acute problem, if the person with dementia is going to become so agitated that, for instance, you would need to give them anesthesia to have them have a dental exam, that the anesthesia would likely be more risk than missing ideal preventive care and avoiding cavities and such. But I think that's a really hard risk-benefit ratio, and I think that often caregivers are awesome at knowing how to be supportive to their loved one with dementia. And luckily, a lot of my patients with dementia are actually amazing at retaining the idea of what a doctor is. And I suspect that this carries over to dentistry as well, and are actually really great about allowing me to, for instance, in my visits, do exams on them. And I suspect that that may carry over to dentistry as well, at least into the moderate stages of dementia.
Does Medicare cover admission to a nursing facility for dementia?
No, that if the person is going there with the idea of long-term care, getting long-term care in a nursing facility, that is not covered under Medicare contracts. That Medicare will cover a short stay for post-acute care settings, but long-term care gets covered first by whatever finances someone has until they qualify for Medicaid, which is what pulls that that coverage. And so getting people to think about those finances, elder law attorneys are great in addition to the financial DPOA, of getting people thinking about their finances in advance and thinking about how to ensure that they're able to get somebody onto Medicaid as soon as possible, while also protecting the caregiver to maintain their own home, for instance. It's a very delicate thing, and something that, thank goodness, there are experts in how to do that.
Okay, and then we're back to the question about dementia assessments, and just to mention that someone had said that they like to use the mini-cog.
So the mini-cog is wonderful for someone who you have, well, so we see it often in the Medicare annual visits. It's being used frequently for all comers to think about whether or not somebody has dementia when you have no concern particularly about it, when it's just a screening exam. I will say that current recommendations are not to screen for dementia out of the blue, but it is used in Medicare wellness visits. And if somebody has an abnormality on that test, then you could go forward with the more lengthy tests that I was talking about, including the MOCA or the SLUMS or the MMSE. That the mini-cog, once you've got a concern that somebody has dementia, I don't think the mini-cog is very helpful. That that doesn't give you enough information about enough different types of domains of loss, and that instead, if you're worried that somebody might have dementia, I would move forward with one of those longer assessments I'm talking about, which are 30 questions or so. Or in complicated cases, there are neuropsychiatry evaluations that can take 4 to 8 hours and do a much, much more in-depth assessment. So different gradations.
Okay, I think we're amazingly through the questions.
That was a lot of great questions.
It was a lot of great questions. It was also quite instructive for me to kind of maneuver all these things. So thanks everyone for your patience. And thanks also to you, Dr. Thomas, for calling back in and putting up with my slide advancing. So thanks. We will conclude, and really appreciate, Dr. Thomas, your sharing your expertise in this area. And we will reconnect again next week. Bye.
Thank you.